All right, hopefully a few more people will join as I'm making this introduction. Good afternoon, everyone. Once again, for those who just joined, my name is Erica Denicola Shear. I'm the Director of Community Education at the Epilepsy Foundation of Northeastern New York, and we are very glad that you're joining us this afternoon for today's lesson on safety in patients with seizures. Today's presenter is Dr. John Pugh from Albany Medical Center. He is a pediatric neurologist, and he's also the Associate Professor of Child Neurology at AMC, Division Chief in Child Neurology, a theme leader of medical neurosciences, and Associate Neurology Residency Program Director. And Dr. Pugh is also the chair of the Professional Advisory Board at the Epilepsy Foundation of Northeastern New York. He has a lot of important information to go over today, so I'm gonna waste no time and hand it over to Dr. Pugh.
All right, thank you very much for the introduction, Erica. My computer just told me that I've been unmuted. Can everybody hear me okay, or at least can you hear me okay, Erica?
Yep, I can hear you fine. And one other thing, if you guys have questions during the presentation, you are welcome to type them into the question bar to keep track of them. We'll have time for questions at the end, so I can read whatever you've entered, or we should have a little bit of time to unmute participants and allow you to ask your own questions. So we'll save those till the end.
Very good. Sorry, my slide advance is giving me a little bit of difficulty. There we go. All right, I have no disclosures to this talk, and I just want to say specifically that I have no relationships with any device manufacturer. I will be talking about some devices commonly used for seizure detection during the third part of the talk, and I just want to make sure that that is clear from the outset. As Erica said, I am a child neurologist, and that's my clinical focus, and that's really going to be the focus of this talk as well, is kind of towards children and adolescents and regarding safety issues. Since I am a pediatrician and I've been trained in things like childhood advocacy, I'm going to mention just some basic childhood safety issues as we go along the way as well. I never know exactly who's going to chime in for these sorts of talks, so some of the information is going to be basic. So if you are a person who personally has epilepsy, or you have a child who has epilepsy and this has been a long-term thing for you, then you might find some of the information in the beginning stages on the more mundane end. I apologize in advance for that, but I'm always surprised by gaps in people's knowledge, even people who I would consider seasoned, and I wanted to make sure that I didn't take anything for granted. So please bear with me if I have some information that you're already very well aware of as we go through. This is the outline for today's talk. I'm going to start first by talking about preventing seizures, then move along to precautions for individuals with epilepsy. Then I'm going to talk specifically about sleep-related precautions and sudden unexplained death in epilepsy, or SUDEP, and then briefly talk about what to do when a seizure happens, including the use of two of the more commonly prescribed abortive medications. So beginning with preventing seizures, a lot of people have seizures that really occur under certain circumstances. And for that reason, we generally advise that people track their seizures and they look for any associations or triggers that they might personally have. And not everybody's triggers are going to be the same, and they can even change throughout the course of their life. So it's a good idea to keep a seizure diary, and a lot of people use seizure trackers. There are various apps that you can use, or even various computer programs that you can use, and even some computer programs or web-based applications which will send alerts to people you designate, including your epileptologist or medical provider. So that's something that everybody should consider. I wanted to do a call out for the Epilepsy Foundation's website. They have a wonderful section on managing seizure triggers. So I encourage you to check that in case you need more information on this topic. Probably the single most common reason for someone to have a breakthrough seizure meaning someone who's well controlled to have a seizure that just comes through, is because they missed medication. It's very, very common. I myself take medication for various conditions, and it's hard to remember to take all of your medicine appropriately all the time. We all lead very busy lives, but it's very important, especially with seizure medicines, to make sure that you take all your medication as they are prescribed in terms of the dose and the time. I spend a lot of time with my patients talking about how they can remember to take their seizure medicines, talking about things like pill counters and cell phone reminders, and making sure that they pair their medication with something that they do every day or multiple times a day around the time when the medication needs to be given. One handy thing that I find is mentioning putting your medicine or putting a reminder to take your medicine with your toothbrush, because most people brush their teeth in the morning and the evening, and often seizure medicines are taken twice a day around that time. But anything that you can do to come up with good mental cues to remember to take medicine or remind your family member to take their medicine is very important. And I must say that stopping medication abruptly or inconsistently taking medication is very dangerous. And oftentimes that can even be more dangerous than being untreated for your epilepsy. Seizures can often be precipitated by periods of illness or periods of stress. So it's pretty common for us to see a patient who has epilepsy who gets a rather run-of-the-mill cold or the flu, and they'll come in and they have a fever and they have a seizure because of that. So for that reason, we spend a lot of time working with patients and families talking about ways in which you can stay healthy, making sure that you maintain a good diet, that you maintain good exercise, and trying to avoid people who have identifiable illnesses. Now, as much as you can, it's good to avoid chronic stress and getting run down. I remember when I was in college, at the end of every semester, right around finals time, I would really sleep horribly, I would eat horribly, I would stop working out, and I would get incredibly run down. And I would almost always get a cold around that time. Sometimes just being run down with those sorts of chronic or acute stressors can be enough to bring on a seizure. I also encourage everybody to make sure that they routinely see a healthcare provider for primary care and that they accept all appropriate vaccinations for their age. Now, given the timing with the COVID epidemic, or pandemic, I should say, I wanted to make sure that I mentioned this in particular. Um, there's no evidence that patients who just have epilepsy are at any increased risk for being infected by COVID-19. They're not more likely to contract COVID-19. They're not more likely to pass away or have a bad outcome from COVID-19 if they just have epilepsy. However, if you have certain medical conditions such as diabetes, high blood pressure, asthma, other lung diseases like COPD, those conditions do put you at increased risk for complications from COVID-19. I would also say that while epilepsy itself does not cause any greater risk of contracting or having a bad outcome from COVID-19, certain medical conditions that are common amongst people who do have epilepsy can put you at increased risk. So patients with cerebral palsy, patients who have chronic lung disease or might have a tracheostomy, or patients who could be on immunosuppressing medicines may be at increased risk for COVID-19. That's going to be the only time I mention COVID-19 during the talk, but I felt as though it was important to at least say a little something about it as a nod to the times. Another common reason for a seizure to happen is not getting regular sleep. We should really all be sleeping about 8 to 10 hours a night. And it's important to make sure, especially in children and adolescents, that they're sleeping on a regular and consistent schedule, trying to avoid pulling all-nighters whenever possible. It's so common nowadays with the work demands in school, or at least it was before the pandemic, for children to stay up very, very late working on papers or cramming for tests or trying to do their routine homework. And that can really be something that can trigger seizures in a lot of people. And it's something I hear about a lot in the high school and college years. You also want to be on the lookout for anything that might impair sleep. So some people, especially if they're overweight, can have a tendency to snore or have sleep apnea. And if you're snoring or have sleep apnea, or if you have funny movements during sleep, it can disturb sleep and disturb the transitions into sleep, out of sleep, and the cycles that your brain does throughout the course of the night, and can even make you a little bit more prone to having seizures. The last thing is that I tell all of my patients to be good about sleep hygiene, trying to sleep in a quiet, dark, cool environment, making sure that they get regular exercise, but not within a couple of hours of when they want to go to sleep, trying to avoid caffeine or napping after 12 o'clock in the afternoon. And I tell all of my children, at least, that beds should be used only for one thing, and that is sleeping. Adults can, of course, use them for other activities, but children should only use the bed for sleeping. Should not be something that's used for homework, shouldn't be something where they go and watch TV or watch videos on their phone or their tablet or computer or whatnot. The more you make those sorts of pairings of the bed as being someplace other than where you go to sleep, the less likely it is that you're going to sleep well in your bed. Flashing lights are a trigger for some people with epilepsy. Now, this is the minority of people, but for some people, they can be very susceptible to certain frequencies of flashing lights. It's a little bit more common in women than in men, and it often tends to be a feature for epilepsies that start a little bit later in life, around the time of puberty, as opposed to ones that start a little bit earlier. Now, there are reports of this going way far back, but one of the most memorable things in recent memory is actually the Pocket Monster incident of 1997. Um, Pocket Monster was actually the original name given to Pokemon. And in 1997, the first season of Pokemon was airing in the country of Japan. And they had a sequence during one of the episodes, which included about 30 to 45 seconds of very noxious flashing lights. And about 700 children in Japan, all at the same time, had seizures and ended up going to the emergency room. That's one of the reasons nowadays why you will see disclaimers or warnings with some television shows, movies, or with video games. So most video games come with that manner of disclaimer now, and people who have children might remember the recent movie. Oh goodness, what was the name of it? Incredibles 2. They had about a 30 to 45-second segment in there, which had some bright flashing lights. And there was a disclaimer that people who were sensitive to flashing lights might want to take special care or avoid seeing that movie. Now, I've had this be an issue for my patients when they go to concerts where there are flashing lights or strobe light effects. Every year around Halloween time, I have one or two patients who will have a breakthrough seizure because they're exposed to strobe lights, either when they're trick-or-treating or they'll go to a haunted house or a haunted hayride. In addition, I've seen this happen sometimes on bright, sunny days when someone is driving. I don't know if you guys ever remember the movie Harry and the Hendersons, but in the initial sequence of that movie, where John Lithgow's character is driving through the Pacific Northwest forest, the light is kind of filtering through the trees just so, and it can create a strobe effect. So I will have some patients, and this is not an infrequent occurrence, where they will have seizures specifically while driving. Now, if someone has a sensitivity to seizures that are brought on by flashing lights, one common recommendation is to make sure they stay at least 6 feet away from a television screen. Another good recommendation is to wear a good pair of sunglasses that have a wraparound feature and polarized lenses. Those two things together help to limit the amount of noxious light and limit the chance for provoking a seizure. Small amount of alcohol will not trigger seizures. So drinking small amounts of alcohol in moderation is generally safe if it's an age-appropriate activity. However, excess drinking, binge drinking can trigger seizures. One reason why that can happen is because people who have a tendency to excessively drink or binge drink also might not be very good about being compliant with their medications. It's important for people who take seizure medicines to realize that if you do choose to drink, that your tolerance for alcohol is often going to be lower than that of the average person because seizure medications can influence or increase the tendency towards getting drunk, basically. I tell all of my patients to avoid illicit drugs. There are many illicit drugs which have been shown to be associated with an increased risk for seizures. That's true for amphetamines. That would be true for things like meth. That would be true for cocaine. That's also true for marijuana. Now, I know that medical marijuana is very in vogue right now, and I know that it is used as a treatment for epilepsy, but it's a specific preparation which is most commonly utilized, which has very low components of THC and high components of CBD. A lot of the marijuana that you get on the street is the opposite of that. So I advise my family or patients to avoid utilizing marijuana. The last thing I wanted to mention very briefly was just the idea of catamenial epilepsy. I'm not going to go into this because Dr. Spinaki-Varelis did a wonderful job at her talk during March, and I saw that she was logged in today. So thank you for that talk, Mariana. But I just wanted people to be aware that there can be a tendency towards seizures during certain periods in your cycle. And if you have further interest in that topic, then you can go back and review Dr. Spinaki-Varelis's talk. So moving on, I wanted to talk about precautions for individuals with epilepsy. And these are really going to be precautions designed to keep people safe. Now, I divided it up into these general categories, and we'll start off with general precautions. And I tell my families that really this comes down to common sense and parental judgment, and that whenever they or their child is going to participate in an activity where having a seizure that impaired motor control or impaired consciousness could cause injury to themselves or somebody else, that they have to be cautious, modify, or avoid that behavior. Now, we have to exercise our own judgment every day, but this is one really important way in which we have to do this for patients with epilepsy. There are certain recommendations that are also just good overall things to remember for children, which I just wanted to give a call out to, which include the storage of medications, the storage of firearms, appropriate helmet use, car seats, trampolines, and pool safety. And I mention these because of the time of the year that we're in. People are spending a lot more time outside and in leisure activities where they are at risk for hurting themselves if they're not following good general safety precautions. Anybody who's interested in learning a little bit more about this, I would refer to the AAP's website on parenting. So the AAP is the American Academy of Pediatrics, and they have a website called healthychildren.org. And they have wonderful age-specific guidance for children at just about any age. So if you go to this website and you click on the teenager or the young adult or the toddler, it will take you through some of the most common recommendations that they make to help keep children safe. The pediatrician in me feels obliged to mention this. One specific thing that I wanted to call out was medication safety. All of the seizure medications that we use can be very dangerous if they're taken inappropriately. And every year I see children who come into the hospital who have accidentally gotten into somebody's medication. Maybe the pill bottle was left out. Maybe a pill fell to the floor and was picked up and eaten. Maybe someone actually took too much medication in a suicide attempt. These are often avoidable. So I just wanted to make sure that everybody who's on the talk thinks about how they might store their medication or their loved one's medication so that it can be done in a safe way. In addition, I wanted to mention trampolines. You see them a lot nowadays. And while this is not an epilepsy specific thing, it is one example of a common practice which really isn't all that safe. Um, the American Academy of Pediatrics really recommends against the use of trampolines in any setting. Even when used appropriately, they can be very dangerous. If people are going to use trampolines, whether this be at a trampoline park or at home, it's recommended that it be one person at a time, that there be no flips or tricks, that all metal is covered, so there's no exposed metal, that it's away from structures, so not too close to a house or a fence or a pool, that it be supervised, and that it be enclosed. So this would be a relatively safe trampoline, but even still, generally not a good thing. Moving on from general precautions for children and patients with epilepsy, I wanted to call out driving for a little bit. The laws for driving vary by state, and if you go to the Epilepsy Foundation website at that URL I provided, they actually have a wonderful list of driving laws by state, and you can look up each individual one that you're interested in. One thing that I wanted to mention is the idea of reporting versus non-reporting states. Some states, the provider, so the epileptologist, the doctor, the neurologist who treats patients, has to actually tell the state that they have a patient with epilepsy or that an individual has epilepsy. Other states are non-reporting states. In those states, it's the responsibility of the individual to report the condition to the DMV or the RMV. New York State is a non-reporting state, which means that physicians don't have to tell the Department of Motor Vehicles that the patient has epilepsy, but people, when they apply for their license, have to disclose that condition. In terms of when it's safe to drive, that really depends upon the duration of seizure freedom. There have been studies on this looking at different periods of seizure freedom from as short as 3 months to as long as 12 months. New York state law technically says that someone has to be seizure free for 12 months in order to be able to drive in New York State. However, they also put this slightly at the discretion of the treating physician or the treating provider, and most providers will use 6 months as a cutoff. So 6 months is a general rule of thumb within New York State about how long you have to go without having a seizure before you can drive. Now, I always feel like a little bit of a hypocrite when I talk about this next session, but it's important for people to remember that it isn't just cars that you have to be careful with. You have to be careful with all of these other things: quads and ATVs, snowmobiles, motorbikes and scooters, hoverboards, this new thing called one wheel, which I think looks like a lot of fun, but I'm worried I would never be able to do it. And even riding lawnmowers. Really, anything that is self-propelled and goes any significant speed, you need to exercise caution with and use that same general rule of thumb that you would apply to driving. Whenever somebody is on something that's not motorized but wheeled, so that would include bikes, roller skates, skateboards, and Heelys. You don't see the latter too much anymore, but still you see them every now and again. You want to make sure that someone wears a helmet and stays away from traffic. In terms of heights, I generally tell my patients to avoid heights taller than they are, so anything between about 5 or 10 feet, unless they have a helmet or a harness. If you have a helmet or harness, you're fine. If you have a helmet or harness, you can go do a high ropes course. You can go ahead and do a rock wall. The worst that happens is that you fall off the wall, or you fall off and you get caught by the harness and you don't really seriously injure yourself. But generally speaking, avoiding things that are more than 5 to 10 feet off the ground is what you should do. That means no ladders. I tell people to avoid bunk beds, and I tell people to avoid climbing trees. Playground equipment requires a degree of judgment. I normally allow my patients, especially if they have well-controlled epilepsy, to use playground equipment without any restrictions. However, some schools are on the more vigilant end, and parents have to use their own discretion about equipment that they feel might be unsafe, especially if their child has frequent seizures. In terms of water activities, the main concern there is a risk for drowning. So we recommend that all patients who immerse their body into water have one-on-one supervision for any sort of activity like that. We typically recommend that people do showers as opposed to baths, and I recommend that people don't lock the door and only do a shower when somebody else is home, just in case they were to have a seizure while they were in the shower and they fall down. In terms of swimming, I generally advise to engage in it with caution and appropriate supervision. Now, I typically recommend a responsible adult who knows the patient has seizures, who would be capable of pulling the person out of water if they had a seizure. I don't like to rely on older siblings. I don't like to rely on 90-year-old grandmothers. It really has to be someone who's capable of providing aid if there were an emergency. Whenever anybody goes into water, I recommend an age-appropriate flotation device. And I normally recommend that people avoid deep water like lakes or rivers unless they wear an appropriate safety device. Um, if you're in the middle of Lake George or Sacandaga Lake and you have a seizure and the water's 40, 50 feet or more, it doesn't matter how closely you're being watched. If you go down, you might not come back up. Other situations. It's good to do a survey of your house and look around and make sure that there are barriers around objects that people can hurt themselves in. So barriers around stairs, barriers around fireplaces, making sure that the edges of tables, edges of counters, that they're padded. Cooking is something that people should be careful of, especially if there's cooking with a gas stove or open flame. You can envision a situation in which someone is cooking and they have a seizure and they fall into the stove. Or you could envision a situation where they're cooking and when they have a seizure or they have some manner of convulsion, that they tip what they are cooking. So I had one person who once was boiling a pot of water, had a convulsive seizure, and the water spilled and burnt them very severely. Got to be careful around power tools. And you have to be careful about activities like hiking and camping. I normally recommend doing those only if you have somebody else with you, and to be careful around campfires. I knew one patient who actually was going for their Eagle Scout badge, and they had very well-controlled epilepsy. But at the time, one thing that you had to do for your Eagle Scout badge was you had to do an overnight camping trip on your own. The patient had a seizure while they were doing the overnight camping trip, and they ended up rolling into a fire and burning themselves rather severely. So the sorts of things that you just have to think about. Finally, I get asked about amusement park rides and fairs quite frequently this time of the year. My default answer is that you have to follow the rules that the amusement park or the fairs have. And a lot of these will have rules that say, if you have epilepsy, if you have seizures, that you should avoid these rides. At the same time, I think it's important for people to be able to live their life and for people to go out and have fun. So if someone has generally well-controlled epilepsy, I think it's safe to do amusement park rides and safe to do fair rides. You just have to exercise your discretion and think about the individual ride and how safe it would be for the person with epilepsy or the people around them if they were to have a seizure. So it really depends upon the exact circumstance and how well controlled the seizures are. I put this slide in here just to show a general overview. So I would consider these to be low risk activities. Routine playground equipment, non-contact sports like golf or volleyball, and aerobic exercise. Things in which you've got to be more cautious. Anything with wheels, anything with water, weightlifting, contact sports, and please notice I put basketball and soccer under contact sports, gymnastics and trampolines, cooking, and amusement park rides. Now, things that I normally suggest people avoid: self-propelled vehicles, heights more than 10 feet, boxing, scuba diving, and bungee jumping. The next section of the talk, I'm going to focus in on sleep-related precautions and SUDEP. So people with epilepsy have an increased risk for mortality, and that increased risk is about 2 to 3 times higher than someone who doesn't have epilepsy. If you look specifically at children, in some age ranges, children with epilepsy have a 90-fold increase in a risk for mortality than people without epilepsy. Now, these are higher, or the risk for mortality is higher, if the patient has a structurally abnormal brain, so an underlying brain condition that causes the epilepsy. If they have active epilepsy, meaning that they're still having seizures. If they are not adherent to their medications, or if they have medically refractory epilepsy, meaning that they've tried multiple medications and no medication has been able to stop their seizures. If you look here, this is data from 2014, and this was the estimated number of deaths that were associated with epilepsy in that year, and there were about 6,000. If you look at how it breaks down, there were various things, some of which we've talked about, that were specifically associated or to which those deaths were attributed. Drowning being one, injuries being another, but you'll see that that biggest bar on the left is for a condition called SUDEP, or sudden unexplained death in epilepsy. And that's what I wanted to talk about next. So sudden unexplained death in epilepsy is a sudden, meaning unexpected, non-traumatic death in a person with epilepsy in which there is no other clear cause. Nobody knows exactly how frequent SUDEP is, and there are a lot of reasons for that, but mainly because a lot of deaths don't get coded appropriately. But one common estimate is that 1 out of every 1,000 people with epilepsy die each year from SUDEP. Anybody who's familiar with the Disney franchise might recall Cameron Boyce, who passed away just last summer from SUDEP. Now, the risk is highest in patients who have medically refractory epilepsy, and in that group, the risk approaches 1 in 150. So that's a pretty significant number. If you look at SUDEP by age group, you'll see that it's relatively uncommon in children, but it starts to peak in in adulthood and then kind of peter off as people get a little bit older. So really the prime years for SUDEP are going to be the years between about 20 and 50. And if you think about it, that makes a lot of sense. Generally speaking, these are people who are living more independently. They may live alone. They might be unmarried or not have a significant other they live with or a caregiver who's looking after them quite as well. These are also going to be individuals who have had their epilepsy for a longer period of time. So those are some reasons why you see that peak in the middle age years. I shouldn't say middle age, but the adult years. So risk factors for SUDEP include a young age at seizure onset, the duration of epilepsy, having treatment-resistant or medically refractory epilepsy, and SUDEP is higher if you have certain seizure types, especially generalized tonic-clonic seizures, and that's really the most important seizure type that attributes to SUDEP. Finally, if you live alone and or sleep alone, you're at higher risk for SUDEP. And that's mainly because most cases of SUDEP occur at night. And often a patient who's passed away from SUDEP is found prone, meaning on their belly. So one thing is, how can we possibly present cases of SUDEP? And specifically, how can you possibly detect or monitor a person at night to help prevent them from having this happen? Well, there were a couple of studies that I found interesting. One of them was by Nashef et al. And they looked at 310 students who went to a boarding school for children with epilepsy in the 70s and 80s. These children were at that boarding school for 2/3 of the year. And while they were at school, they were supervised by audio monitoring at night, meaning that basically someone had a monitor and listened in case something abnormal happened while they were sleeping. In 4,135 person years, meaning of 310 students, each student spent multiple years there. So you look at the number of person years spent at the boarding school, they did not have a single incidence of SUDEP. However, there were 14 cases of SUDEP which occurred when the children were not at the boarding school or after they graduated. Another interesting study was done in the United Kingdom, and they looked at 54 cases of SUDEP, and they compared those cases to about 600 controls during the 90s. And what they found is that if there was someone keeping an eye on the patient at night, the risk for SUDEP was markedly lower. For people with a statistics background, I put in that data. Trust me when I say that that's actually a pretty significant correlation. And there were different methods of monitoring that were used. In some cases, it was just a room partner, so a co-sleeper, maybe a partner, maybe a parent. In some cases, a monitoring device was used, and in some cases, people just checked in on the patient frequently throughout the course of the night. Now, there are lots of different monitoring devices that are on the market now. Generally speaking, there are devices that detect movement, there are bed sensors, there are devices you can wear, and then there are a couple of other sorts of monitoring or safety devices that I'll talk about. If you talk about devices that detect movement, one of the more common ones is going to be the SAMI sleeper system. Now, basically, this device is, sorry, my mouse isn't working. Let me try this. That's not working either. Well, this device is a camera that's installed in the room, and the camera pairs to a tablet or a phone, as you can see. And what happens, well, this is going to be a problem, Erica, because if I can't
So
navigate.
John, I can see your mouse moving. So right now it is hovering over the image.
Interesting.
So perhaps I can navigate you back over the image if you
Yeah.
move your mouse to the left a little bit.
Yeah.
Up, other left. Sorry, other way.
No, and what I want to hover over is where it says Sammy in yellow text with a red background.
Okay, so try moving your mouse to the right a little bit. It might be a
Okay.
mirror image. Up a little bit more, just a little bit more. You are now down just a little, and you're on it. So
Oh,
try clicking. Did that
and it
work?
just advanced. That didn't work. I'm going to exit here,
Okay.
and now I'm going to restart it.
Okay.
And now my cursor is magically back.
Perfect.
All right. So this is the SAMI sleeper system, and what I'm going to do is just go to the company's website.
This is a quick demo of the SAMI Sleep Activity Monitor. The SAMI camera is installed on a wall opposite the bed. The iPod is located in your room. When the SAMI app is launched, it automatically connects to the camera and displays a live video stream. The camera has a microphone that is easily turned on and off. The camera is very sensitive to motion. In this setup display, the red shows the motion that the green meter is measuring. Sammy will ignore short movements, such as rolling over. If motion continues, an alarm sounds. The display switches to live view, and the microphone is turned on.
So this is one of the more common monitoring devices that patients either tell me they're using or will ask about. And all this really does is it detects motion during sleep and then alerts you if there's something that it considers to be abnormal motion. Another monitoring device is the MFit device. Now the MFit device, this one down here is a slightly older model. This one here is a slightly newer model. But the way this device is designed to work is that this piece goes underneath the mattress above the box spring at about the level of the bed where the chest would be. And this can detect movements of the patient at night. And it can help to determine whether or not the patient is having a seizure based upon the quality of movements that are detected. Now, this is reported to be able to detect micro movements, including breathing, and might even be able to detect movements as soft as heartbeat. It can also be used as a bed alarm in case someone falls out or gets out of bed. Oh my goodness. I think my device just had a seizure. I don't know what just happened there. Sorry about that. Nowadays, we all are walking around with portable electronics, or most of us are walking around with portable electronics. And people are often using biometric devices, which work by either monitoring movement or by monitoring the pulse and oxygen and sweating that our skin has. Most of these work by detecting rhythmic, repetitive movements. And the idea there is that people who have a seizure, especially a tonic-clonic seizure, during the seizure, they'll have rhythmic and repetitive movements that can be detected by the accelerometer within the device. Now, the most common example of this is the Embrace watch. This is the only FDA-approved monitoring device that I am aware of, and it senses both movement and electrodermal data. So by electrodermal, what I mean is how warm the skin is, as well as how sweaty the skin is. Now, this requires a prescription. To give you an idea of how it works, we'll go to their website, and they've got a nice little video.
This is Sophie. She hopes and dreams a small watch on her wrist, the world's most advanced wearable for seizure monitoring, cleared by the FDA, Embrace 2. It uses advanced technology and AI to continuously collect physiological data. Sophie can connect Embrace 2 to her phone via Bluetooth in just a few taps. And as soon as Embrace 2 detects a possible generalized tonic-clonic seizure, its companion app, Alert, will send an automated call and SMS to the caregivers that she has chosen to notify. The SMS will also include her GPS location so that her loved ones can come to her aid wherever she is. Embrace 2 is made for both adults and children, like little Tommy.
Now we'll go back to the presentation here. So basically, these devices have a detection mechanism that mainly focuses on movement. Then there's an alert mechanism so that the movement is detected and then an alert is sent either by text message or phone call somewhere. And that is received by someone who can then come and give aid. Now, the Embrace 2 is not the only device like this. There are several other devices like this. One of which that was actually around beforehand was the Smart Monitor. Now, the Smart Monitor is actually just a software pack, and the software pack will actually sync with most smart watches. So it'll sync with like the Apple Watch or the Samsung Watch. And it has a data storage and reporting ability. It'll record any time, it'll record the date, the location, the duration of any sort of abnormal movement that it detects. Now, you can access that data yourself. You can also share that data with other individuals. This app and a lot of the other apps that are like this also have things built in like medication reminders, or they'll just have a help button, almost like a medical alert sort of alarm, so that you can call someone even if you're not having a generalized tonic-clonic seizure. Now, all of these devices, the Embrace 2, the Smart Monitor, they function based upon having monthly subscription fees. And I pulled this off of Smart Monitor's website to give you an idea of how expensive these things can be. Mind you, this is not for the equipment, this is not for the app. This is just for the monitoring that you need after you've had the initial purchase. I should also mention that, and I pulled this directly from their website, a lot of these devices are not necessarily approved or hold up to scientific rigor. So even Smart Monitor says that it makes no claims about its ability to be able to detect seizures, and it says that it's not a medical device, and it's not intended for the use or treatment of disease. It's meant to be an activity monitor. So you've got to be a little bit careful when you're looking at these sorts of devices and understand exactly what the product is saying it can do and how what it can do may or may not be helpful for you. So these also have some limitations. One of the first limitations is that they don't detect seizures. They detect movement. And not all rhythmic movement that you engage in is going to be seizure. For that reason, there's a high incidence of false positives and the possibility for false negatives. A false positive is when you detect something that is not a seizure, but identify it as such. A false negative is when you miss a seizure. So I had one young lady who was a percussionist and she played the drums at school. And every day when it came time for band, her device would go off. People who tap, maybe even typing, can be rhythmic enough to trigger these devices. Another issue is battery life. The Embrace 2 says it's good for 48 hours on a charge. I'll tell you that most of my patients who have this sort of device, they find that they're lucky to get a day out of these sorts of devices. Finally, you've got to consider the possibility for a loss of privacy or loss of autonomy, especially for teenagers. Other devices that bear mentioning: if we're just talking about nocturnal monitoring, you can use something as simple as a baby monitor. They're a lot fancier than when I had young children, but still, this can allow you to hear someone while they're sleeping, and often a seizure is associated with the epileptic cry or inspiration at the onset of seizure, changes in respiration, gurgling sounds, or thrashing movements during the seizure. They do make some special heart rate and oxygen monitors. So these are basically pulse ox machines, like what you would have when you're in the hospital. The one depicted here is called the Owlet, OWLET, and it is a pulse ox monitor that's made to go onto a child's foot, and then it pairs to your mobile device. In addition, there are anti-suffocation pillows, and you can see that this pillow kind of has an egg carton sort of surface. There is no FDA-approved device like this available in the United States, but these are used in Europe and specifically the United Kingdom, or at least they are marketed there. And you can envision how this could help to prevent someone from smothering in their pillow if they ended up in an inappropriate condition, because the corrugations in the pillow can help to have some airflow, help to maintain some airflow. Erica, I'm bumping up on 12:50. I'm debating whether or not I go to what to do when someone has a seizure, or if I just open up for questions. What are your thoughts there?
Well, we can check in and see if there's any questions at this time. I don't see any in the chat. If anyone does have a question, probably the more efficient way is if you use the function, I'm speaking to attendees now, to raise your hand so that I can see if you have a question you'd like to ask. There should be a button on your toolbar that looks like a little hand, and if you push that, I'll know that you have a question and I can unmute you. And I don't see anyone putting their hand up. So I guess we can keep going, and if there's questions that come up at the end, then we can address those.
Sounds good. All right. So when you're thinking about what to do if there's a seizure, it's very important to make sure that you have a plan ahead of time. And that really comes down to having an action plan. Now, there are lots of different medical conditions that have action plans. One of the more common ones is the asthma action plan, which describes what to do if you have an asthma attack. Seizure action plans contain the same basic information. These are most commonly used by schools, but they can also be used by caregivers. So if you have a patient, if you have a child, I should say, who has epilepsy, then you can give a copy of an action plan to a babysitter or a relative, or even the parent of someone who they go to visit. The most frequently used seizure action plan is that provided by the Epilepsy Foundation, which I have depicted here in its newest iteration. Now, action plans have basics information on them. First, they typically have a description of the seizure. Then they tell you what to do if there is a seizure. And then they tell you when and what medication to give to help to abort a seizure. And that leads to the idea of seizure first aid. The first thing I tell people is to stay calm, time the seizure, make sure that the patient is safe, and if they're conscious, to offer reassurance. Remove any unnecessary people in the environment, and this is mostly geared towards the school setting, but it would also apply to a public setting. Make sure that you stay with someone while they're having a seizure. Do not place anything in their mouth. It's surprising nowadays who still thinks that it's a good idea or afraid that people might swallow their tongue. And after the seizure, allow a period of rest before they have to return to normal activities. There are several abortive medications that are given for prolonged seizures. The most common is Diastat, and Diastat is a rectal preparation of Valium. Until recently, it was the only medication approved by the FDA for the treatment of a prolonged seizure. Just within the last year, we've had Nasolam, which is intranasal Versed, approved, and there are a couple of other things which healthcare providers sometimes use. These are normally used for people who have a seizure that goes on for more than 5 minutes, or by someone who has several acute repetitive seizures, meaning several seizures in a row. Diastat comes in a twin pack that looks something like this. It comes with 2 syringes, a lubrication pack, and instructions on how to administer it. The syringe itself has a little green ready band. It has a display window which tells you the dose, and it has an expiration date. In order to give Diastat, you place the child on their side, and anybody, when they're having a seizure, they want to be placed on their side. That helps to prevent them from smothering. That helps to prevent them from choking on any excessive saliva or vomit that might occur during the seizure. You want to remove the cap from the device, and you want to apply the lubricant to the device. Once you've done that, you want to pull the pants down and find the rectum, or I should say find the anus. And then you gently insert the medicine, and notice it only goes in so far as that little flange at the end. I've had some people who got carried away and inserted too far. So it's important not to do that. You then use a little circling motion to kind of clear away any poop from the side walls of the rectum. And then you depress the plunger slowly over about 3 seconds. The medication comes out kind of thick and goopy like preparation H. So it's got a little consistency to it. Once you've given the medicine, you want to close the butt cheeks and then remove the syringe and then keep the butt cheeks closed for about 30 seconds. Otherwise, sometimes the medicine leaks out. Sometimes if you stimulate the rectum, it leads to pooping. And then afterwards, you want to make sure you watch the child closely. This is a central nervous system depressant. It makes you tired, it relaxes your muscles, it lowers the heart rate and lowers the blood pressure. And rarely people can get into trouble after getting Diastat. I've never personally had that happen, but you should always make sure that you pay close attention and monitor someone after they've received it. Now, this is Nasalam. This is the intranasal preparation of Versed. It's an interesting looking space-age little device. This is the part that goes into the nose. This is a little plunger down on the end of it, and this is the handle. This is the same basic delivery apparatus that's used for Narcan. And the way that it works is you hold it just like so. You put it right to the nostril, and you can see that you advance it to the nostril, and then you have your fingers held right against the patient's face. Then you depress the plunger, and it just gets squirted up one nostril, and that's all you have to do. That was the last thing that I had to say. So now we really will open it up to any questions that anybody else has.
Okay, great. I still don't see any questions entered into the question chat, but again, if you look at your control panel and speaking to attendees, you should see a little button that looks like a hand. And if you click on that, it'll show me that you have a question that you want to ask, and I can unmute you if you'd like to ask it. Dr. Pugh, I don't think I see any questions.
Wow, that
Oh,
means I
wait, I do have one. Okay. Sorry about that. So someone asked, is Nasalam covered by insurance yet or still in process after the FDA approval?
So it is covered by insurances, but I find that insurances are very reluctant to cover it for everybody. It's only FDA approved for children or for individuals 12 years and older. And I found that insurance companies are very rigorously sticking to that 12-year-old mark. I have had it approved for every child above 12 and over who I've prescribed it for, but anybody under 12, it's been uniformly denied.
Okay. And someone is thanking you for the very informative webinar. And someone says, my son turns 12 this summer, so perfect, thanks. Great.
Good for them.
All right. So if there are any more questions, please feel free to enter them. I do just want to say that if anyone has any questions after today's presentation is done, please feel free to send me an email. You should have my email address through all the communications through GoToWebinar. So if anything comes up, please feel free to shoot me an email. I'm also happy to share that seizure action plan that Dr. Pugh went over. And I have all of your emails from your registration, so I will just follow up and send that. And if you'd like to keep it, you are more than welcome to. And you have a couple more thank yous from attendees, but I think that's it for questions.
All right. Well, thank you very much for tuning in to listen to me, and everybody stay healthy and stay safe.
Thank you, everyone. Have a great afternoon.